Good afternoon, and welcome to Creating a Population Health Strategy That Scales, a webinar tweet chat combo from healthsystemcio.com, sponsored by Allscripts. Just a little housekeeping before we get started today. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your webinar moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in the separate browser or on your phone by using the hashtag HSCIOchat, and you can view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today for you to submit your questions. You can send them in as they occur to you. Just leave the default set to all panelists, and we will take them towards the end of the program, but go ahead and send them in as they occur to you. And you can download the deck by using the URL on your screen. It's at the bottom of most of our slides, and it's also being sent out in the chat box. Just so you see how we're going to spend our time today, we are going to hear from our featured presenter, Renee Broadbent, AVP of Population Health IT and Strategy with UMass Memorial Healthcare. We're going to hear from our sponsor, represented by Phil Morris, Solution Specialist Manager, Population Health Solutions Architect with Allscripts. And we are going to have our Q&A at the end. We're going to mix things up a little bit today, and we are going to hear first from Phil, and then we are going to hear from Renee. So, without further delay, I want to turn it over to Phil. Phil, thanks so much for joining us, and thanks for sponsoring.
Thanks, Anthony, for the invitation and the opportunity to speak. Thank you very much. I'm going to spend a few moments here talking about what I call a formula for successful population health initiatives. At Allscripts, we see population health as building these open, connected communities of health that rely on a variety of different types of technologies. So in our point of view, population success is creating streamlined communities of care focused on smarter, integrated care. You may be looking at-risk populations. You may still be in a predominantly fee-for-service world. But the idea in successful population health is to build a formula that connects team members and stakeholders together so that they're working in a smarter and more streamlined way. In this regard, I've defined success as a combination of different components of a single function. The first element of success is to build well-defined multiple disciplinary goals. And Renee is going to talk about that as part of her presentation. You need to identify early what you want to measure and align best practices and peer review measurements with understanding how you're going to achieve those goals, and then monitor your success as you move toward those goals. There are other elements of a successful formula, but these sources will always include a variety of different types of information. A lot of the work that I do spends time with customers understanding how they can use all types of data to build a successful population health platform. This can include financial information. It should definitely include clinical information. And then more and more, it's including information from outside of your organization, such as public health, social data, activity-based cost accounting, data from your payers, and even licensing. The next component of a successful population health formula is using enhanced data from anywhere. And that means that not only are you getting data from what are traditionally your payer populations or your payers, but also from all types of clinical providers, their social care, the behavioral health care system, family support team members, and transportation, etc. Another component of success is coordinating teams and engaging stakeholders. And here I want to make a point that you're not just engaging patients, because in a successful population health formula, everyone is a stakeholder. That includes all the providers, all the social care teams, and all the patients and their caregivers. The last point I want to bring up with regards to a successful population health formula is incremental agility. And in this case, I mean the idea of avoiding vendor lock-in and anticipating changes that can happen in the market, in technology, and in the population health campaigns and programs that you're putting together so that you have options that remain open to adjust to those changes. As the government starts to change how they're going to be monitoring and managing your success toward population health goals, like they're doing right now with MSSP and Pioneer ACOs and other types of programs, being able to adjust to those changes and then actually build on those practices to build more advanced population health campaigns is going to be a critical success formula. So when you think about how you want to build a connected community, typically there are 4 main pillars that will describe how that community should come together. The first one is aggregating data and building connectivity between all the providers and all the stakeholders. The second one is working on a strong business intelligence and analytics program that can transform that data into insights so that you can understand how to stratify your populations, manage at-risk populations, and to get information back to the care providers so they can address typical things like gaps in care. Care coordination is going to be very important. Care coordination is the third pillar in the group because that's really where the people of the process all come together to manage the information that will bring patients more toward success of their goals and interventions. And the last important pillar is patient engagement, because while healthcare occurs a lot of times during encounters, we need to remember that healthcare also occurs a lot between encounters. So having a patient engagement platform that is vendor agnostic, that will reach across all the different visits and connect all the different team members so that patients become more responsible and more active in their healthcare will be important aspects as well. At Allscripts, we're doing all of these by connecting hundreds of clinical systems to feed data back into the workflow. This doesn't require rip and replace. Remember, I started the presentation by talking how you want to streamline connected communities by avoiding vendor lock-in. Analytics, in our case, is based on an industry-leading business intelligence platform, and we've got fully engaged data scientists building predictive and descriptive models to help you understand your at-risk populations. Our care coordination pillar is a cloud-based platform that sits above all the different EMRs and interacts with those so that everyone can participate in successful evidence-based interventions. And then our patient engagement platforms both address long-term care through a patient portal and more immediate care through an interactive artificial intelligence chatbot that can keep in touch with your patients between the visits and protect their health as they move forward between encounters. My last thoughts that I can offer up regarding a successful formula for population health is this. First of all, measure what's important, because if you want to change it, measure what's important if you want to change it, but remember that most people hate change. So as Renee will speak to, bringing together the groups so that they can be participants in that change and manage that change as it goes forward is going to be important. Focus, because it's very easy to get overwhelmed. I've seen several population health strategies and campaigns struggle because they tried to boil the ocean too fast. Listen, because ideas can come from anywhere. This isn't just a doctor-only type process or a payer-only type process or an executive-only type process. Good ideas on improving healthcare and building a stronger, smarter integrated care model can come from anywhere. And the last 2 points are always think about a feedback loop. Moving data through a system from left to right or moving processes from start to end is important, but the feedback loop concept is very important in lean manufacturing and Six Sigma programming, and it has a very strong place in population health program success as well. The last point is it's never too late to start. Many of my customers have been hesitant in dipping their toe in the water regarding population health because they get overwhelmed and they think perhaps they may have missed the boat, and that's simply not the case. This is where healthcare is going in the 21st century, and it's very easy to step onto the boat and move forward with everyone else. Anthony, thank you for the chance to speak. That's all I have for today.
Awesome. Thank you so much, Phil, and we look forward to including you in the Q&A. Without further delay, we are going to turn it over to our featured presenter, Renee Broadbent, AVP Population Health IT and Strategy with UMass Memorial Healthcare. Renee?
Hi, Anthony, and everybody who is attending today, and thank you for attending this presentation. I appreciate your time today. So it's a fairly lengthy presentation, so I'm going to go through the essential elements of building a population health management program. And hopefully all of you can hear me. I had a little technical difficulty with my headset, but we seem to have fixed it. So for today's agenda, we're going to cover some essential categories if you're going to build a population health management program. And those include where you need to make some investments, how you integrate strategy and development, what management structure is most helpful, what kinds of logistical barriers that you're going to run into, and some tools to kind of overcome them, and the importance of education and communication in this process. Now, there's a lot of slides in this deck, but there are two, and when we get to them, I will point them out to you, and I believe those are the most important takeaways that you can have today when you're trying to build out a population health management program. So for our learning objectives, you should be able to walk away and say, I kind of know where I need to spend my money to build out this system-wide population health program, list the elements of developing and managing the program, describing some of the logistical barriers, and understanding the role of education and communication in meeting these system-level goals. So a little bit about UMass Memorial Healthcare. We are the largest healthcare system in central Massachusetts. That's the middle of Massachusetts to the west of Boston. We are a clinical partner with UMass Medical School, and this gives us great strategic advantage in terms of having access to technology and research and clinical trials. It's truly a great partnership. We have multiple campus locations. We are in downtown Worcester, and there are several sites here. Health Alliance Clinton Hospital, which is east and north of Clinton and Burbank and Leominster, and Marlborough Hospital. We have 1,600 physicians on active medical staff, about 3,000 registered nurses, 12,000 employees, and about 1,100 hospital beds, and that covers all campuses. So this is a nice visual. This is our geographic footprint. It kind of shows you our service area, which is pretty large. To the west, you'll see a circle by itself. That is one of our participants in our ACO program. So the Population Health Management Organization, the way it's constructed here at the health system, it is an internal organization within UMass Memorial Healthcare. It sits at the system level, and when I say the system level, it is a system level service, very similar to a service like HR or IT or finance that services the whole organization. So it's responsible at that very highest level for influencing and developing the population health management strategies. We manage multiple programs. We're in an MSSP Track 1 ACO. However, as most of you know, you continue to evolve that model and take your next direction about where you're going to evolve to. Bundles, we have commercial, and we have participated in a Medicaid pilot. So the Population Health Management Organization has a staff consisting of about 67 folks. That includes the administration and the senior leadership team, care management, we have physician leadership, data analytics and reporting, account management, and network support and development. We'll get into a little bit of each of those through the presentation. We have 1,700 participating providers. That number is actually low. We're upwards of about 2,200, and we cover pretty much the gamut of the state. Across programs, our beneficiary counts run about 150,000, and that number fluctuates depending upon our ACO attribution. We have many internal relationships as well as partnerships outside the organization with the medical school and community organizations, and that is to help us facilitate population health management across the board from start to finish. And we also have additional hospitals that participate in our programs that sit outside our health system. So, for example, they're affiliates of ours and beyond. So investing in a system-wide population health management, your objective is to create a clear picture of population needs and value-based performance. And that's, as mentioned previously, this is not an easy task to do. It's challenging. And some of the areas that you need to focus on are data consolidation or data aggregation. Now, that's a term that gets used in a lot of different ways, but essentially what you're trying to do is get this pool of information from your beneficiaries from lots of different data sources and making it meaningful so you can actually figure out how to manage that population. And for us, we have 32 different EMRs from our independent ACO providers. And by that, I mean all versions of the major players as well as a couple smaller Massachusetts-based companies as well as some homegrown provider systems as well. In addition, in our mix, we have about 2% that are still on paper. We integrate claims, and we have multiple internal systems up until 10/1 of 2017, where we have a single patient record. We have an analytics platform that collects, integrates, and analyzes data from all sources. It develops our quality and medical expense, TME, and we're really heavily utilizing now, when we've aggregated all this data, for predictive analytics to help us provide opportunities for population health improvement. We do have an analytics population health enterprise strategy that incorporates the school and as well as us to try to drive this effort. And we have robust operations because we are investing in our people and our processes and technology. So when I started off, I mentioned a couple of slides that I thought were important for you to understand. This is one of them. Take this away and you have everything you need to know to put your framework together for population health management. You need to complete a strategy regarding this, and it's hard because a lot of things influence it. There's government influence, there's budgeting, there's care management. Those are constantly things that are going to be in flux. So you have to build a flexible framework that allows you to manage to that and then continue to build out a successful program. So if you look to the left, there's a nice little screen print, a nice little picture. It'll show you all the different pieces that you need for your organization. But what's really important is that little black box down the bottom that says Population Health Information Technology and Data Infrastructure. Without your data, you don't have your program. The data is what's driving, and your infrastructure is what's driving, helping you build out that program. So think of it as a house. When you're building a house, you don't build a roof first. You build the foundation first and go up from there. So within our organization, we have a number of strategic initiatives associated with our care management. So if you'll see, we have care management, practice engagement, and care pathways. And so we're trying to build out strategy, we call them strategies and tactics, for each of those initiatives to actually manage the population. So if you look at care management, you're going to see 4 areas that we focus on, and those should not be surprising to anybody on the phone. Those are typical issues that you're challenged with in a population health management organization: readmissions, ED utilization, chronic disease management, and post-acute care. We also have practice engagement. We're trying to engage our primary care practices as partners for practice-based care management. And so the things that we do with them: what are our standard patient practices? How do we do risk identification and stratification? How do we use our care management teams effectively? We do have care managers. However, you know the populations are large. You can't possibly manage every patient in the population, so you have to find ways to effectively define that and then manage them. And then care pathways. So our clinicians developed best practices, for example, in the bundles or specialist engagement, to actually define those pathways to standardize for the practices. So breaking it down even further, you'll see our care management pillars, and each of those pillars has a line of tactics and reporting. So you'll notice that each of them has a lead, and then they have specific functions within each one of them that we have to achieve. But the most important thing about the slides is to look at the bottom and the metrics. One of the things that we find most effective when we're developing our strategies is, what do our metrics look like? So each of our initiatives has metrics that tie to them, and we continuously monitor them, both from the quality, both from the and the TME side. And so that's a continuous improvement process that we do. And these things are built, however, they are flexible and can change based on our metrics reporting. And you can see from this slide, we break it down even further. It goes into a project lead. So these are well-staffed, and these are cross-functional folks. So there's care managers, there's project managers, there's performance improvement facilitators, which we'll get into very shortly. But we work together as a team to build and support that pillar. Now, this is a report outcome that we share. Now, we have a number of reports in our Office of Clinical Integration that we share for transparency purposes. This is a Tableau Visualization, and we have a lot of these. So I'm not going to go into a deep dive. I have several pictures and screen prints in the presentation, but it's to give you an idea of how we're managing medical, for example, the Medicare ACO total medical expense. This is kind of how we help educate ourselves, as well as our providers and our care management, about the target population we want to look at, where are people falling into, and what kind of costs we are incurring, and what part of our population, because we may make other decisions about how to manage that population. one of the things that helps us in our decision to manage population is our patient risk matrix. So in the 4-quadrant matrix, you'll notice you have healthy, rising risk, sickest, and urgent. So you have to make a decision as a population health management organization on who you're going to manage, how you're going to treat, and what kinds of protocols you're going to handle in each one. So for example, the healthy folks, you really want to build in strategies that focus on prevention and wellness. And then your predictive analytics comes into your rising risk, who is bubbling up and on the cusp of moving into your other quadrants of as sickest and urgent. And each of those has different functions and different treatment options to help manage. And obviously your goal as an organization is to keep people in that lower quadrant and not have them get all the way to illness and trauma, because then it becomes more difficult to manage them. It becomes more expensive. In our organization, we have a management structure. So if you're building out your house and you're trying to look at what your population health management organization is, you have the Office of Clinical Integration, and we support different functional areas. So it's a multidisciplinary team. We oversee lots of different programs, including Medicare and Medicaid ACOs. And the functional areas are quality reporting, our payment guidance program, which deals with our incentives, practice improvement facilitation. We have compliance, state and federal regulatory and policy impact analysis, data aggregation and analysis, which is, of course, near and dear to my heart because I'm from IT, utilization reporting, care management, coordination, SNF utilization, and engagement and decision-making opportunities. So these are all the different areas that are supported by those 67 people that we referenced earlier on in the presentation. My screen doesn't want to change. There we go. And so this is another example of some of the quality reporting that we do. This is for our commercial payers. And, you know, there's some information that's been redacted out for privacy purposes. But you can see we constantly look at these types of things and share them with our providers as well as our care managers as well as our docs to really try to help manage to quality for our organization. In addition to creating the reports, integrating the clinicians with the practices, we also employ practice improvement facilitators. We call them PIFs, so if you hear me refer to that, that's what I'm talking about. And practice facilitation is a supportive service to help the primary care practice. So I think of our PIFs as account managers. They literally are assigned practices throughout our ACO, our owned practices as well as our independents. And they spend a lot of time working with these practices. They use a range of organizational development, project management tools, quality improvement. So, for example, they are instrumental in helping us file for GPRO. They work with the practices to get that done. They go out to the practices. They bring back things that the practices are struggling with. They help them with workflow. They help them with reporting. In addition, our reports that are supplied, and even though they are pushed out directly to the physician, they go out and they explain and identify areas for improvement. So they're very integral in how we manage our primary care. And they go out, most of the time they're on the road, but we do supply some telephone. We do and conduct webinars. And sometimes they're just informational about what's going on and what they need to be doing. And we try to build those webinars around times that are convenient to them, and they are also recorded for future use. And so this isn't our slide. This is from the AHRQ, but if you build an effective PIF program, these are the types of services that they can offer. We really believe in our PIF program. We feel as though it has given us measurable differences in how our physicians respond to us when they participate in our programs, and they're very, very engaged. About a year ago in our senior leadership team, we added a chief compliance officer. And the reason that we did that is because this particular area of healthcare that we're going down that road, it changes all the time. It changes at a federal level. It changes at a state level. And unfortunately for all of us, unless you're really into this stuff, it's a lot to manage for everybody to try to keep up with it and come up with a cogent strategy for the participants in our organization to actually understand what needs to be done. So we hired a chief compliance officer, and that individual's role is to make sure that we are meeting all the compliance goals, that we understand what regulatory, both federal and state, are coming down so that we can share and communicate with our participants. So we implemented an analytics platform and a data consolidation strategy. So we take our data from all these sources, we mix them together. We've developed an IT plan for integration to the hospital's EMR, and that's currently functioning, so we're exchanging data with the hospital EMR as well, so we have the fullest picture of our population base. We are focusing now on developing even more enhanced reporting, predictive analytics, and actionable data, and helping us formulate data governance around all this information. We constantly look to add different data sources. So right now we're starting to collect information. We have other systems that collect information off their SNFs. We are expanding our other facilities, and we are also establishing relationships with various HIEs throughout our New England as well as other states. And then I want to talk a little bit about what other systems are needed to support a population health management office. So I look at our organization as a business, and therefore there are business systems that are important to you to help you manage it. We use, and you're seeing it more and more, a very long time ago we started talking about implementing a CRM. And so we use a CRM, and it helps us manage a number of different things, including a complete picture of our ACO organization, as well as our managed care network. We have lots of information that comes through that, and we actually communicate through that. So it's instantaneous, so we always kind of know what's going on in our organization. We recently used it to apply for and receive HIMSS Level 6 certification. So the second slide that I think is really important for you to take away is the conceptual model. And so for me, from a data perspective, this really kind of answers everything that you need to know. So data aggregation, you start at the very left side of the screen, and you pull in data from a variety of sources. And here we've referenced UMMHC because this is a slide I use internally. And then that data comes through a process, and it gets, attributed to a patient, it gets provider attributed, there's patient matching. But the important thing is the right side of the screen where you see what parts of the other organization it's providing. So this is all contained with the Office of Clinical Integration, but we are supporting care management, reporting analytics, and business management. Another report for our ACO management report is this is our Medicare function on our overall ACO performance. So you'll see a pretty little state over to the left and the lower side, and it kind of gives us an overall picture of our organization and how well we're performing. And then also our TME report. So we obviously, one of the things that we're trying to do in this organization is reduce our total medical expense for the areas that we talked about before. So we're constantly building these reports and analyzing them and identifying opportunities for us to minimize that expense or improve that expense. Another integral part of our organization is our post-acute network. So we have a preferred SNF network, and this kind of shows you the process that we go through. So we profile SNFs who wish to be in our network. We then do a telephone screen of those SNFs, and our team here is really, really a tough team. They do a great job. We narrow it down to site visits, and then they come to us, and we recommend the high-value providers. Everybody knows this SNF is patient choice. However, we have an ever-expanding network of preferred SNFs. And this is the criteria that we used. So UMACO is the name of our ACO. It's UMass Memorial Healthcare, UMass Memorial ACO. And to the left, you'll see our minimum requirements, and then our expectations. And what we found initially was that some of the SNFs were, wow, why do we have to do this? Now what we find is most of the SNFs want to be in this program, and they seek to stay in this program. So once you qualify, you have maintenance items that you have to be responsible for. We have a complete auditing group that continues to make sure you're meeting those minimum requirements. And if you don't, you get a visit. And you can actually be removed out of that group. But we're finding more and more we have an ever-growing list, and we are able to help them achieve that preferred status, which is, in the end, much better for our patients because it gives them better choices. We also do patient outreach as part of our service we offer to our primary care physicians. We have a group of folks who do outreach to patients for things such as wellness visits, colonoscopies. We really want them to continue to do that, and that's a service we offer to our primary care. So if you're not getting the sense of it now, what we're really trying to do is how do we enable our doctors to do better? How can we help them? We can give them reports. We can give them support on site. We can do outreach for them, really all in the name of better health care for our patients. So this is our 4-quadrant patient mix. So that quadrant that I showed you before, this kind of gives you a scattering of our stuff. This is a point in time. Again, this is really just for information to kind of show you how we produce data using our aggregated data from our claims and our data sources to actually produce and analyze this data. This is another example of a Medicaid report. So this has some data redacted out of it because it's by clinician, and we give them the report, and this is how we help them manage them. So this would be an example of a report that a PIF would take out and work with a provider on. So what do I think are the most important things or some of the challenges that you're going to have in terms of getting this to go? One of the biggest things is you have to have executive buy-in. So OCI, the Office of Clinical Integration, we have to change mindset. So what we're talking about in this move to value-based care is a cultural change, and it's really a hard thing to do. If I look back on some of the projects and some of the organizations that I've worked with, right, what have we asked our physicians to do? How have we asked them to change in the last 12 years? It's probably quicker than any other entity, you know, going from paper to complete automation. And it's a lot, and then tying that automation to payment. So it's a huge change that influences the culture and how we provide care. And so to get it to be successful, you really need your most senior executives to have buy-in and help you drive that cultural change. And you need your system leaders to be engaged with that. One of the things that we do with we have boards and we have committees that we meet with is we heavily utilize our data and analytics to show how these programs can help, how we can improve patient care, and how we can streamline and reduce TMA. The second component of that is to secure physician buy-in. We know the physicians have gone through a lot. It's frustrating. You know, we have to work on things like, okay, how does a monetary incentive have to change? How are they going to be rewarded for modifying their behavior to do this? Some of the things that we've done here, it's not particularly unusual, is to put in what we call a pod structure. We have a pretty big group as well as one that's dispersed geographically. So essentially we've broken the quadrants into pods and we've assigned a pod leader to each one. And that's a physician group. And we generate reports to the individual, for the individual physicians to see how they're performing against peers. We then create meeting structures so that the pod leaders get together and we evaluate what's going on, where they need to have improvements, what education we can provide to them, what other support mechanisms that we can do, and they feed back out to the participants within their group. And this is just an example of how it all integrates between the pod leader and the medical director and how they interact. What I think is really important in this piece is how we give the physician right down to the practice level a voice in the process, an opportunity to express concern, the opportunity to share victories, and opportunities for continuous improvement. It's a really good engagement tool, and we've had a great deal of success with that. So how do you overcome logistical barriers? And you will. You'll get cultural barriers. You will get resistance just for resistance purposes. What you really want to do is you want to use your data and your analytics that highlight savings and impacts patient care. Provide report cards and scorecards to help visuals of actual performance and opportunities. Where are your financial improvements? Have you demonstrated reductions in total medical expense? How are your patients engaged? How are your providers engaged? Where are your rising risk populations? What are your care management interventions look like? So all of those things are going to present barriers to you, and if you're using the data and you're managing it correctly, along with education, along with integration, along with meeting with folks, you'll come a long way to making those improvements. So for us, I go back to our metrics. We love to measure and we love to do metrics. But here's some statistics that we've kind of gathered to see. We provided in practice improvement and facilitators who conduct about 100 practice visits a month, as well as sort of a resource. So they'll actually go in and do work with the physician too. Our outreach contacts 9,000 plus calls. We produced about 230 HCC coding audits. We offer a care management team which has managed more than 7,000 patients, which is actually a great accomplishment. You know, keep in mind those patients were all varying degrees of illness, some more severe than others. And from our standpoint, here's where we saw some improvements. Our average inpatient admissions per patient decreased by 15% against the control group. Our average 30-day readmission rate decreased by 15%. Our average ED visit rates decreased by 18%, and our average skilled nursing admissions increased by 19% versus the control group, which was 41%. So we look at this to see where we're making these improvements, and those are significant numbers. Now, those numbers may fluctuate periodically, but the key is to have the structures in place for continuous monitoring so that you can keep those improvements in place. One of the last things I want to talk about is education and communication. I'm a big believer that you can't over-communicate. So some of the things that we do is our senior leadership takes rotations into different organizations. So we go out, we meet with their leadership teams, we meet with people doing the work. So this is work over and above of what our performance improvement facilitators work on. We want the senior leaders in those organizations engaged. Some of them, you know, sit on our boards. We really work on the senior leadership team to have that one-on-one engagement. We have our pod structure. We do community collaborative efforts. So, for example, UMass Memorial Healthcare and Reliant Medical Group just joined partners to offer community help, which is a social services connection for our patients to be referred to for social services. So we constantly look to reach out to the community to enhance those services. One of the things that I'm most proud of is our leader is not overly technical. And we got him very technical in a very short period of time, and he is able to send out weekly blogs. That notification goes out every week. We talk about different things to our constituents. They are able to interactively participate with him. We also communicate all the regulatory changes that are coming that we feel like our physicians need to be involved with. What are the GPRO processes, any program updates that they might need to know about. And then we have a program called PHM Wins. These are our weekly webinars that we conduct for people to participate in and get educated on in terms of the organization. So for recommendations, if you're going to go down this road, and it's not an easy road to go down, you have to develop a clear strategy. That strategy also has to have some level of flexibility in it because of the regulatory component and the changing organization. You need to consider all pieces of the care delivery continuum, including your staffing, what's it look like, what's the money count, care management, how will that be built in, education and training, and how your reporting is going to go up. You need to secure your executive and physician buy-in. Develop a clear financial plan for a PHN for its return on investment. You know, nothing gets to everybody's heart like seeing the money come through. Create and support dedicated teams to support the strategies and execute the programs. It can't be piecemeal. When I recently presented this at HIMSS, several organizations came up to me and had different parts of their organization handling different pieces of population health management. And unfortunately, that's not going to work. If you don't have cohesion on the delivery, it's not going to work because everybody's going to think they're doing the right thing, and at the end result is not going to be a clear strategy. Use the data analytics, get the right systems in place. So, you know, do you need 100 different pieces of software? No, but you probably need more than one. You probably need some good data analytics. You need some good CRM. You need access to good information that can process things like claims and EMR data. Start with clearly defined strategy. Provides a series of system goals, and then most health systems will likely need more than one. So just continue down that path and building out that infrastructure. And so, you know, we all love change. It's good, but we like to think that we're going first on that. So with that, Anthony, I've finished my presentation.
Awesome. Thank you so much, Renee. What an excellent presentation and lots of great information in there for people to take away. All right, let's jump into our Q&A. First question, Renee, do you see a role for CRM and digital marketing professionals in population health? And I think you're going to say yes because you mentioned CRM, but you go ahead. You go ahead and answer.
Yeah, no, actually, so when we started with our CRM, we originally thought, well, you know what, we have our ACO participants in like multiple spreadsheets, and a lot of it was driven around, you know, getting data that was clean and, you know, consistent. However, it is subsequently expanded out. So we're doing a lot more integration with not only the ACO, but our managed care network, as well as our larger health system entity in terms of other things, including most recently doing things regarding research and all that. And our physician liaisons who go out and kind of basically sell the services of the hospital, they use it heavily and manage it for things like, Stark payments and all that. So I really do think that the CRM can be integrated very nicely into the healthcare market. Some other areas that I'm looking at is some of the cloud-based things for care management. So I strong believer in a CRM.
Around the technical issues of integration, are you looking at integrating the CRM system with particular like the EHR or any other kind of application?
You know what? Yeah, so that's recently come up. We are looking to expand that out. We just did convert about 6 months ago to a new EHR, so we're still probably in the process of stabilization, so that's probably not a project for this year. However, that is a future state type of thing that we're going to be looking at.
Awesome. Phil, what are your thoughts around CRM and making use of it in population health?
I'm sorry, was that question directed to me or Phil?
That was for Phil. I'm sorry.
Okay, sorry.
I think it fits into the strategy just as the way Renee described. CRM, it's about building a 360-degree view of the customer. That's the way it's usually talked about. In this case, you're building a 360-degree view of the patient, and as I said in my part of the presentation as well, the other stakeholders who are part of that process that surround and support the patient. And those can be patient caregivers, those can be the SNFs that Renee mentioned, or other ancillary facilities, and of course those are the major players as well.
Excellent. Okay, thank you, Phil. Renee, next question. High and rising risk is important, but have you set your attention to the healthy patients yet? And I guess, quote unquote, healthy. Otherwise, there wouldn't be patients. Well, maybe there would be.
Right.
What types of what types of programs and outreach?
Okay, so, if you looked at that 4-quadrant risk, right, you do have the healthy population that's down there, and you certainly don't want those patients to kind of go, switching over, to the other quadrants. Our patient outreach program really focuses working with the primary care practices on the preventative type visits and things like that. So, patients often, especially, Medicare population, not going for their well visits, not really, and providing the education around that. So our outreach coordinators really work with the practices as well as the patients to call about the visits, to remind them about the visits, to make sure they get scheduled for the visits. And we're actually looking at the process for enhancing that piece of it to just take that quadrant that's healthy and really keep them in that quadrant.
Phil, any thoughts on that? Phil?
Sorry, Anthony.
Okay.
I agree. Usually what happens from my experience is that the well patients kind of get left off to the side. And then everyone realizes near the end of the measurement year, calendar year, they need to get those people back inside the facility to deal with well patient visits or screenings or other types of assessments. Having a more comprehensive view of the patient, and from all the data sources we've been talking about today, gives you the opportunity to moderate that patient flow throughout the calendar year so that you don't get any surprises at the end of your measurement period.
All right, very good. Next question, Renee. How do you collect and aggregate data from so many sources? Is it multiple technologies depending upon the data source?
So we use a vendor agnostic tool that can accept data in a variety of formats, because one of the things you have to remember is that you have clinical practices that are enormous, have their own IT people, are pretty sophisticated, down to a one doc practice that maybe doesn't have that sort of support, right? So we identified a tool that was, doesn't care what vendor you are, doesn't care what file format, can accept multiple formats. And we basically get that data from the sending system, and then it pulls it into a normalized database that we then take and utilize in with the claims to create that further picture. Now, that aggregated tool does not perform the analytics piece of it. It really just takes, scrubs, cleans, and mixes the data. We do have another tool that does all the analytics that is basically an analytics tool. So we have two.
Okay. All right. Next question, back to CRM. Do you view CRM as only a patient engagement tool, or do you think of it more broadly to include reaching out to prospective patients? Is this a separate tool?
Well, you know what? The tool that we have can do those things. We have not leveraged it to reach out to prospective patients as of yet, but definitely you could do that. And it could be fully developed to be more of a patient engagement tool. I think that's something that requires careful planning because, you know, one of the things that's important to remember is that patients don't readily engage with technology. I mean, look at all the different portals and platforms you have for your different EMRs. They have a pretty low participation rate, but a CRM certainly could be used for that. We have not leveraged it yet to reach out to prospective patients, but certainly that's an application that could be done.
Phil, do you have any thoughts around that?
Back in the old days when dinosaurs roamed the earth, I did a lot of work in advertising, and what you're talking about there is what we used to call campaign management. If you're going to reach out to prospective customers, you're really building a campaign. So think about it in that framework and moderate through those types of steps, and you'll understand what your retention rate is, what your callback rates are, and you get and of course, as I said in my part of the presentation, look at feedback because that requires A/B testing and looking at different options to understand how you can moderate or change your message to reach a larger audience.
Right, and so to dovetail to that, so within a CRM, they have a function called campaigns. And we do use that to do sorts of surveys to gather data, and we do measure that and metric that and graph it and utilize that information to make decisions about our participants.
Very good. All right, next question. Are your groups utilizing CPT-2 coding, and I hope I said that right, to help stratify your patients based on severity of their comorbidity and for data analysis?
Yes, our data analytics team would use that.
Okay. All right. That was a good answer, nice and concise. Next next question. The human factors, often when we're involved in technology, talking to high-level technology folks, and often we hear it's the challenges are more around dealing with the people, those darn people, as opposed to technology. Renee, do you see that as being a fact in your work, or the most difficult issues having to do with people and change versus technology, and how do you go about dealing with that?
Well, first of all, I think any change, I'll take it on two levels. The first level is how we are developing or migrating the change in healthcare is culture and about people and modifying behavior and how they think about it. Secondarily to that is how they handle the technology that comes along with it. I think that I try to be very empathetic, having been being a technologist, that I get that this isn't easy. We try to kind of break people in easily on this stuff, and so if there's education that needs to be done, we try to first do it that way, bring them along, have them understand it. I think the people part and the cultural part is more difficult, but once you have people there, I think that the technology can be more readily embraced. The second piece of that is that the technology can't be complicated. The last thing you want to do is make it much more difficult for a physician or somebody treating a patient to have to spend all their time pointing and clicking. So we try to take it in a two-pronged approach.
Right. So what are your thoughts around that? Obviously, as a vendor, you bring software to the market, and then Renee's out there, putting it in, putting in different types of software, trying to get people to use it, and it's a battle between what is good enough to be considered usable, and when can you insist somebody use something and say, no, this is easy enough, your complaints are unreasonable, versus, yes, that is a lot of clicking, and you are being reasonable. So just your thoughts around that, Phil.
Oh, wow. Okay, that's an hour-long presentation itself. But let me try to put some context around it. I want to make just a comment to something Renee said, and I'll come back to answer that question. We talk a lot about end user, how comfortable the end users are with the technology. I just want to make a note to what Renee said as well. It's also important to consider the technologists who are implementing this type of technology, especially the legacy
IT team because they want to feel like they're improving the model and adding to the process and that their skills will be valued as well. And I have never seen a population health product that was successful without considering how the legacy IT team can contribute to the process as well. So it's not just about the new shiny fangle stuff, it's also about how all the team members, including the legacy IT team, can fit into things as well. Everybody needs to understand that they're the change model. Speaking to the idea that you mentioned there about ease of use and clicks and stuff like that, when I looked at the large implementations of other vendors' platforms across the federal space and across the commercial space, I've seen a lot of, we've bought the software from the vendor, we've done the analysis and believe this is the right platform, and now we're going to spend the next 2 years changing the way that vendor built their software to model the things we're already doing now. And that's where I think a lot of clicks get added to the process. My advice to anyone considering technology, the technology for my company or anybody else's is, look at that technology and understand how well it can help you adjust to change and how it doesn't keep you from getting locked into a particular solution. Build on top of that to models and behaviors that work toward what you want to be, not toward what you're doing now, because otherwise you're just building a different type of mousetrap and you'll end up in the same situation in 3 or 5 years down the road.
Good, very good. All right, one more quick question, then we're going to get going. Back to CRM. So a lot of questions around CRM. If you were to use your CRM platform in campaign mode, who within your organization would be leading those efforts? Would it be IT, clinicians, marketing?
It would be our organization in the Office of Clinical Integration, which is the combination of technologists, administration, care managers. We would develop the campaign here. We would see that, I would see that as part of the population health management strategy, and therefore we would be responsible for developing that.
Okay, one more quick question that just occurred to me. Do you ever see things going on, Renee, outside of your department that you feel should be brought within it?
Yes, definitely. You know, one of the challenges you have, you know, some of this stuff is like herding cats. So, you know, we might see something else going on that could be folded in. So, for example, without getting too specific, you know, some people making some great strides in home health or telehealth. Okay, how do we integrate that all in? So they may not come under our umbrella, but we seek to create a relationship so we can incorporate it as a service or a process or as part of our strategic plan as well. So it comes across externally as more of a global service.
Very good. All right, well, I think we could have gone a little bit longer, but we're pretty much out of time. So with that, I want to thank everyone. I want to ask you to take a moment to answer our post-event survey when you close out your WebEx window. Regarding continuing education, attending our events gets you 1 CEU towards the CHIME CHCIO certification program, so let CHIME know you were here. And if you've asked us to do so, we certainly will. If you need a CEU program for another, and a CEU certificate for another program, you can see the final slide in this deck. You'll receive an email. Our archive recording has been posted to our YouTube channel. I'm sure that's going to get a lot of interest. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to see our upcoming schedule of events. So with that, I want to thank our speakers, Renee Broadbent and Phil Morris. I want to thank Allscripts very much for sponsoring this event today, and I want to thank you, our attendees, for continually showing up at our webinars. So with that, everybody have a wonderful day. Thank you.
You too. Thank you for the opportunity. Bye-bye.